The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent.
Hello, and welcome back to Code Lavender, the podcast where we shine a light on real experiences of nurses and healthcare professionals. I'm Dr. Ashley, and with me is my amazing, talented co-host, Tanya, the optical nurse. And we're here to provide a safe space for real conversations about nursing, wellness, and everything in between.
Hi, everyone. September's a really important month to us. It is National Suicide Awareness and Prevention Month, and it's also National Sexual Health Awareness Month. So today, we're actually going to blend these themes together in a very powerful conversation.
That's right. And, on a serious note, suicide remains the most devastating crisis in healthcare, amongst others. And unfortunately, first responder professions, which here at Code Lavender is near and dear to us. And our goal today is to talk and about hard conversations, but to have a good time and break the stigma, celebrate resilience of the caregivers who keep showing up for our patients and their families and the communities. So before we get into this, I am so excited and honored to welcome a dear friend of mine to be our special guest today to the Code Lavender podcast. Joining us today is Desiree Morgan, and Desiree and I met, and I think we kind of trauma bonded during COVID. Totally. We were both nurse executives trying to figure out how to get our staff through this. But, present day, Desiree is a senior nurse leader. She has 21 years of experience. She has 2 decades in behavioral health across New York and New Jersey. She's double board certified in psychiatric mental health nursing and nursing executive leadership. And currently, she is the Assistant Vice President of Nursing for the Department of Psychiatry at a very large academic teaching center in Brooklyn. I'm very proud of Desiree, and I'm happy to call her my friend. She has been recognized as one of American Health Council's nurses to watch. She teaches our young nurses in behavioral health as an adjunct professor, and she is serving as a stigma-free ambassador in Washington Township, New Jersey, and spends a lot of time advocating tirelessly for breaking down barriers in mental health. So Desiree, thank you so much for coming to Phillipsburg, New Jersey to hang out with us today.
Yeah, we're so excited to have you on today, especially during a month where we are talking about suicide prevention and sexual health awareness, 2 areas that really kind of tie deeply into behavioral health and overall well-being. Welcome, Desiree.
Thank you. I'm very, very excited to be here. So thank you.
Good. So let's start just at the heart of your expertise. You've been in behavioral health for almost 20 years, and you have done everything from child and adolescent care to forensic and geriatric care. I always smile because we find the most interesting people in this space. And I just want to know, I don't think I've ever actually asked you, what drew you to psychiatric nursing and why are you so passionate about it?
It's funny because it was probably my worst clinical in nursing school. I wanted nothing to do with it, but I think it really rolled back to the fact that my clinical instructor was not presenting it in the light that it should have been shown to me as a new nurse, as an impressionable nurse. I think she had probably her own feelings that were coming through, and that was taking a toll on the students. And so it was not on my radar at all. Actually was an end-of-life pediatric nurse for the first 2 years of my nursing career. And I made a switch based solely on proximity to where I live. And I live 4 minutes from the largest psychiatric hospital in New Jersey. And I said, you know what, let me work there, and then maybe I'll do it per diem. Let's see what that's going to be like, and I'll keep the other job. I was probably in the door about 4 minutes before I realized this is where I need to be. Wow. So I think, what keeps me in this space is that I feel like I can do the most good there Yes, of course, I loved working with babies. I've loved, working in other areas of med surg and ITCU and all of those things with the medical field. But when it came to the psychiatric component, I felt like they were very much a misunderstood group. And for some reason, I was immediately drawn to this population.
That's awesome.
Yeah.
So, in light of talking about suicide awareness and true prevention and just letting people know there's resources, but, talking numbers, which I think often help us really grasp what's going on. According to the CDC, suicide is the 11th leading cause of death in this country. And that I feel like it shouldn't be on the list. I understand that cancer and things kill people, but this is just horrible to hear.
Yeah.
In 2022, for example, 49,000 Americans lost their lives to suicide. And if you break that down, that is one person dying every 11 minutes.
My God.
And for every suicide, there are many, many attempts that don't result in death.
Ashley, as well, among healthcare providers like us, the risk is even higher. The studies show nurses and physicians face higher rates of depression, burnout, and suicide compared to the general population. And in groups like veterans, police officers, and first responders, the rates are significantly elevated as well, often because of the trauma and the chronic stress and the shift work, just wreaking havoc with our circadian rhythms and a lack of mental health support, actually. In fact, as we began our research for this show, we kind of flipped over a few rocks that were very, very alarming. To show just the statistics of nurses in particular committing suicide, and it was so profound and significant and sad that we've decided we're actually going to work on a follow-up episode talking solely on this topic.
Yeah, and I think just something that was just eye-opening for me is when I was looking at research, and I think I specifically looked at police officers, and I think everybody in this room has some kind of a tie to a police officer or two or many. I know, Desiree, you're married to a police officer, and that's our support here. It's our group here, but I was baffled because there is a pretty valid research study with backup out there, because me and my research. But police officers of any variety are more likely to experience a traumatic event, obviously due to their work. And I'm like, okay, fine. 800 times is the estimate a police officer witnesses a traumatic event. Somebody who is just a person walking around in their lifetime experiences the average of 3. So I just was like, how do you even process that? And then 56% more likely to die by suicide than any other profession. God. I just, it was baffling to me, and it's going to start my wheels turning about what resources are these men and women getting, or is it really out there for them? Are they really accessing it? Are they afraid to access it? Are they ashamed to access it? But I know it's an issue.
Desiree, you've been in the forefront of the mental health leadership in one of the busiest cities in the world. From your perspective, what would you say are the biggest challenges nurses and providers face today when it comes to suicide prevention?
So I definitely want to go back to the police officer and nursing, the likeliness of them taking their own life. I'm going to go back to that for sure. One of the barriers, I think, for nurses for suicide prevention, as a nurse, not just with the patients, right? We're talking about for them personally. I think that we don't do a good enough job of recognizing that it is not the job to choke it back. It is not part of the job to just have to be okay with things. So I think we have to normalize crying, right? A release of tension at the bedside. We have to normalize that. So in my organization, and it was, I work with some of the most incredible minds, and they definitely set the wheels in motion prior to me even being there. So I'm learning from them as well. But they do something called a postvention. And I feel like this should be mandatory across all healthcare, across, anywhere where you are community facing.
Yeah.
If it's police department, if it's the ambulance, firemen, anywhere where you are in working with the public and you have a potential, untoward event happening, I feel like it should be a mandatory debrief that happens right after. Now we call it it's very easy to say debrief because certain regulatory bodies want you to have this paper filled out, and that's what it becomes, a paper exercise. But if you actually take it and you make it a postvention, and you have true professionals who get the people involved and the people you've told those stories to, because there's secondary trauma also, right?
Yeah.
Your loved ones who are like, oh my gosh, you're going to go out again tomorrow and do the same thing.
Yeah.
So there's trauma there as well. Marriages get destroyed, and that leads to other stressors for the people who are at the front line. So there's a lot of work to be done with the people who are taking care of others. And I think postventions should be something more that are thought of, where you have your social workers. By the way, that's the space for social workers to be not at the patient's bedside, and not at the community's bedside, but at the people who are dealing with community afterwards, to kind of debrief them, allow them to be in their fields. The other piece I did want to get back to is I've come across, I was also a council person in my former life a couple years earlier. And one of the things that I noticed was we did have police officers that would pull me aside and talk to me because of my mental health background. And they would say, what can we do? Or I have a friend that's going through something,
right?
Because they themselves felt afraid to talk about some of their own struggles, because what happens the minute a police officer says that they have any kind of depression or sadness, you're going to take their gun.
Yep.
Right.
Yep.
So we take away their ability to be open and to ask for help when we cut down their very livelihood. I mean, we create,
it's almost punitive.
Absolutely. That stigma is what is our hugest barrier. Across the board, and it shows itself in so many different ways.
Interesting. Yeah. No, that's great. I love that postvention.
Yeah.
I really want to hear more about that. That just sounds just brilliant. Yeah. But even if it is just a paper checklist, I mean, it's a start. It's a gesture to open the conversation and have a dialogue, and we can take it where we need to take it from there. But just even sometimes it's a prop.
Yeah. So let me tell you real quick how that works right now. If there's something that happens, I'm going to use in a unit, right? You're a nurse and you have a suicide. You walk in there. Unfortunately, there was a suicide or an attempted suicide or something horrible happens. Not even a suicide. Let's say it was a baby. Something happens to the baby. You're in ICU. You lost a patient you didn't think you were going to lose. Whatever the situation was. After you have your debrief, a lot of times it looks like this. Did we do everything well? Was there anything else we could have done different? Is anybody hurt? Does anybody need to talk to anybody? Everyone says, no. They sign a piece of paper. It literally takes 10 minutes and it's gone. It has zero value. It meets a checkbox. That's all it does.
It's theater.
Where a postvention puts people in a room at a time when it's convenient for them, around people who can feel free to discuss and talk about what's going on. It could be a WebEx. It could be done with no cameras. It could be done just to hear. There's a lot of different ways that we could do it that really hold more value.
Oh, I love it. That's awesome.
Yeah, I think too, when we talk about PTSD, I know like in my own practice, there's acute PTSD, and of course that can happen to anybody in any situation, not to be judged by us what qualifies. But there's chronic PTSD, and that's truly the definition, is when it manifests for 6 months or longer. And so I think the thing that I also see that we lose track of is checking a box and saying, is everybody okay in public, in front of everybody, when they're still in that state of post-event shock? That's not enough. Nobody comes back, later. And I was telling a story the other day. So when I was a brand new nurse, I was 6 months in, and I don't know why I'm still a nurse, actually. I assisted in a C-section in the middle of the night where there was no anesthesia used. And I'm not going to get into it because I don't like to talk about it. And I was 20 years old. I was not even capable of legally buying myself a drink to cry about it afterwards. And the baby died. The mother obviously did not do well, but nobody even asked me if I was okay afterwards. And they sat over me, 3 of them, at a table much like this to make sure I charted appropriately. And I wasn't offered a day off. There was nothing. None of my colleagues acknowledged it because obviously it was awful. There was no anesthesiologist in the hospital that night. I mean, this is almost 30 years ago. Things have changed, but I always think, and I remember like I wanted to quit my job, but I actually had to go back to work the next night. So, and I just remember like, at the time, I just kind of said, oh, okay, this is what happens. This is what this profession is. Now I'm sitting here going, that was not okay. This is not okay. All these things, they're not okay.
Absolutely.
So,
absolutely.
It's
And we really need to have a space where we give people a voice, like to be able to do that. Right. And that's what the birth of the hotlines that we have, at least in my hospitals, and I know where we used to work.
Yes.
There are compliance hotlines where you can see if you feel something, you can submit something in there anonymously. But those, unfortunately, there are far and few between opportunities like that. Yeah.
Yeah.
Yes. And, when we talk about suicide, because that's what we're here for today, it's not just these statistics and this like general conversation. It's people. These are people's families. It affects communities at large, and it might be professional communities or just the community we live in. And, I think we know, like we see heartbreaking losses all the time amongst famous people. Take, for example, Robin Williams. I mean, he's one of the most amazing guys I've ever seen. I think he was so funny. He was a funny guy, right? So it's like, how did that happen? Kate Spade. I mean, she's sitting on top of the world, or so perceivably. Naomi Judd, Anthony Bourdain, all these famous people all lost to suicide.
Yeah. And I mean, when celebrities die by suicide, it brings awareness, but it also shows us that no one is immune, not health, or rather not wealth, not fame, not success. And it does remind us why open conversations really, truly matter. And, that's just a part of our mission at Code Lavender, is to create a safe place for all nurses to talk. I mean, anybody really, but I mean, especially our sisters and brothers, you're not alone. We stand with you no matter what.
So I think, we want to take a little bit of time today to talk about this. It's difficult. It's not fun to talk about, but it's really important. And it's important to understand stages that a person may go through prior to suicide, because, oftentimes when you talk to families and loved ones and coworkers and whoever of somebody who has this unfortunate outcome, they're like, oh, well, maybe like this little thing was going on, but we don't recognize it. And I think like when I was looking at stuff and kind of making promotional stuff to get people to join us today, it was just kind of like, hey, ask your friends if they're okay. Like actually pose the question, like ask them.
Yeah.
We were just at work the other day, and there was a person sitting in a meeting who said nothing the whole time. And this is a person who always talks. And so that was in my head. And afterwards, I'm like, you okay? And the answer was absolutely not. And then it went from there. But, I think looking at different stages and what people might go through, what are the warning signs? How can we help somebody when they're not feeling great about what's going on for them?
Well, yeah. And I mean, it's because suicidal progression, it's not a straight line either, Ashley. And it certainly is not inevitable. People, they tend to move back and forth between these stages sometimes. And, an intervention can happen at any point. And that can be the intervention that actually stops the suicide and is life-saving.
Yeah. And I mean, Desiree, I think like, I work so much with vulnerable populations and we talk so much about vulnerability and risk factors. And so in your expertise, what kind of puts a person as somebody that we might say, okay, this is somebody we should do a risk assessment on or talk to a little bit more, probe a little bit, like what might make somebody a higher suicide risk?
So the obvious things, right, like that we all know about are loss, family loss. What I like to say is to everybody, when I teach, I teach a trauma-informed course in my role at work. And what I say is we're all one circumstance away from knowing what our minds can handle. And you can be on top of the world today and have a catastrophic thing happen to you. And you're just not thinking clearly and have that impulsive moment. So those are things where there were no signs. There was just a vulnerable, dark moment, and things look very different at 3 o'clock in the morning than they do at 3 o'clock in the afternoon, right? That same problem. So some of the things I would look for is, are they sleeping more? Are there differences in their patterns, right? Are they sleeping more than they were? Are they not doing the things that they used to like to do? Are they withdrawn? Are they quick to be irritable? Also, depending on what we're dealing with, is it an adult or is it a child? Because aggression could be a sign of depression in a child, but it's very not recognized that way. Because we look at an adult, you think sadness, you think crying, you think not taking care of yourself, all of like the textbook stuff. But if it's a child, sometimes it's my stomach hurts. They're aggressive more. They're fighting. They're picking. They're picky. They don't want to do things, and they're cranky. Those are ways of their bodies feeling saddened, and it's amazing because it's completely opposite from an adult. Most adults will just turn it in, or turn to alcohol. Maybe they're drinking more. Those kind of things. Are they missing work? Are they late for work? Are they hyper-focused on one area? Are they trying to get all their ducks in a row, but they never have done that before? Are they in the preparation stage? Like these are all things that, they're not going to be obvious. It can be super subtle changes, and there could be no, you can rack your brain. And that's the worst part about the people who are left behind after a suicide is the blame game, right? They think, did I miss all the signs? Sometimes there just aren't signs. There really aren't. People make a decision in the moment because who knows? Social media is a huge thing. Who knows if your child's being bullied, right? You ask them all the time, is everything okay? Are you not going to the party tonight? I happen to have a set of twins, and one goes to the party all the time, one doesn't. If all of a sudden I noticed that one that was going to the party all the time isn't going out so much anymore, I'm going to check in with her because there's a behavioral change there, right? So you also have to not be afraid that you're going to plant something in their mind if you start talking about, is everything okay? Are you, anything going on? You can, whatever. People are afraid to have that conversation. It's just better to close it off. If she wants to talk to me, if they want to talk to me, they'll come to me. So,
yeah, definitely. I think that, just familiarizing yourself with the stages, certainly as a healthcare practitioner, within your family. I mean, or if you have a loved one who's a healthcare practitioner or a first responder, it's not the worst idea because a lot of times that's what we look at all day long is one trauma after another. Yeah.
And I think too, like you hit on a couple more things I wanted to talk about is suicidal ideations, right? And I think many, many people feel down enough here and there to think like something along those lines. And then, what is it actually? And as you pointed out, the triggering event or the crisis that puts them at that exact moment. And, it's kind of like just a perfect storm. And I think you talk about trauma-informed care, which I do a lot of that. And, I think I've been looking a lot I've been doing some work looking at trauma-informed caregiving because we have past experiences in our work that affect us when we're taking care of the next patient like that. But, I think one of the things too is we have to realize is that for me, something that might be my triggering point could be something, the loss of one of my children, as to where it could just be a loss of a job for somebody else. And it's not an equal playing field, but anything can, so I think talking about trauma-informed care and what does that really mean?
Mhm.
Like, what does that mean?
So trauma-informed care in the space where I've been teaching is, first of all, leading with empathy, understanding, I like to say in the medical field, you put your gloves on, you consider everybody, contagious and infectious, and that's your universal precautions. In psychiatry and behavioral health, our universal precaution is trauma-informed care. Assume everybody's had trauma in their life and speak to people in a way that you think this person might be. Like I say, everybody carries like this proverbial backpack, right? And through the day, we collect stones of all the things that go on in our life. You woke up late, or your boss is being whatever, difficult, or your kid is sick, and whatever's going on in your life, those are little stones that we keep collecting, and we wear them around with us. If you go to work, how you respond to the rest of your day, you go anywhere, how you respond to people is going to be a little different depending on how much weight you're carrying. And that could be trauma, right? That's the trauma you're carrying. So if everyone's carrying backpacks, we're all coming from a place of, when we respond to people, when we talk to people, we could be triggering whatever that trauma is, because they're not wearing a sign that says, hey, this is my trauma. Please don't talk to me about, you look great, you lost weight, because I just did, chemotherapy and I wasn't trying to lose weight. That could be a trauma for them, right? You don't know what somebody's trauma is. So trauma-informed care is be mindful, be careful, be sensitive, and know when you start to activate. If somebody says something to you that's like a little microaggression, they're not necessarily like being a jerk to you. That's your own trauma, like activating. And so that's trauma-informed care. It's just to be mindful, recognize when it's activating in you, and understand that if somebody's responding in a certain way, it's probably something activating in them that's coming from a place of trauma.
Yeah. And, I think that's true of where we work, our coworkers, we all do it, right? We just want to strangle the person we're working with today.
Right.
And, I think it's one of the things in healthcare and in just public service, anybody who's working with people, especially in vulnerable states. So our first responders, our police officers, and our healthcare staff, what do we have to change to prioritize if we really want to reduce the stigma and start really saving lives? And because the other thing I think we always have to remember is, on the other side of it, those of us who are taking care of people, our police officers who are in very dangerous situations, we snap, right? And we make maybe bad choices, or we make mistakes because of it. So what do we have to change to support people?
Oh, that's a loaded question.
I know it is.
So,
because I don't know the answer to it. I've been trying for a long time, as you know.
So I've had some pretty phenomenal people that I've worked with, and everyone's trying to answer that question, right?
Right.
Some of the things we need are definitely at the most granular level. So one of the most creative things that I've seen when I was an adolescent director of nursing was one of the school systems was breaking the stigma. At the end of the day, the answer is we need to break the stigma. We need to increase the conversations. We need to create a space where conversations are safe and accepting and normalize these words. We can't whisper about mental health anymore. You wouldn't whisper if somebody has cancer. We have to look at it through the same lens. So one of the things that I think there is a huge potential to kind of do everywhere, and I'm a little disheartened that it hasn't caught on because of the stigma. It hasn't caught on with all of the school systems, but one of them in particular in New Jersey is doing a wellness fair. And during the wellness fair, you have to go to stations during your gym. So every single child has to hit this station. You don't get to choose which stations you want to go to. So there's the nutrition station and there's this station. There is a mental health station, and you must collect resources and show them on the way out that you've collected from each one of these stations, from the nutrition, from the mental health, from the, whatever, no smoking or whatever. You have to collect the resources that they've given you to get your ticket hole punched, to get credit for that class period. That way, every single person hit that table. And no one person was seen walking over to the table. Oh, look, Desiree has issues with her mental health. She's over at the mental health table. And I feel like if that was done routinely at a young age, we would easily normalize the conversation.
Yeah.
You know, so those are my thoughts. And the same thing on back to school night, parent night. I feel like there should be tables set up, not just for mental health, for all different things, right? That resources for parents. And they should have to go to them to get the stamp so their kid gets a special thing the next day. And if you do it at a young level and you start the conversations early, it creates more of a trauma-informed kind of thought process while their minds are developing, while their egos are developing, and it becomes less of a stigma moving on. But we're not there yet.
Yeah.
No, definitely not. You're in fact a stigma-free ambassador, are you not?
Could you tell? Could you tell?
So, I mean, that sounds really, really like a great idea of introducing it to, younger kids and just sort of treating it like oral care or ocular health,
Right.
or just another thing that we do as healthcare practitioners to bring that into something that we're looking at. I think as well as nurses, Ashley and I have said this so many times, when you've got them, in your chair, on the table, and you're doing an exam, check in with them, say, hey, how you doing?
Yep.
Yeah, you good? What's going on at school?
Yeah.
Are you sexually active? Have you smoked? Are you drinking? Because as it turns out, and I think we've had this conversation, Ashley, that in fact, you don't just wake up at 21 and become an alcoholic. These kids have their first drink at 10, 11 years old.
Mm-hmm.
So why don't we ask them when they're 10 or 11 years old if you've had alcohol? Why don't we ask them what's going on inside here?
Right.
Yeah,
Right.
it's, we've got this perfect golden opportunity to talk to our younger patients. Let's take advantage of that.
Right. I agree. You can mold them early into healthy lifestyles, right? Or at least into healthy conversations.
And just teach them, like, I'm an adult, I am here to take care of you. And this is a safe place for you to talk. And I actually care about the answer and you can trust me.
So you just gave me such a great, segue. I wanted to say that too. I think there's even an opportunity for a broader acceptance. If you're a pediatrician, there could be a complete overhaul to the paperwork that a parent fills out when you go to sign your child up for pediatric work, right? In this office, we will screen for X, Y, and Z, starting at age 9, right? We will be, we would love for you to be part of this conversation. And that's an opportunity. And it's probably billable because, it's all about the dollar line. Yeah,
But you will find a space.
Exactly. But they could have a 10-minute conversation with the parents that would help them then further those conversations at home, right? You're not asking questions, but you're opening the door to these questions, like what's an acceptable, thing to talk about? This is not taboo. We can talk to our kids about smoking and about whatever, how they're feeling. Are they accepted? Is there bullying happening? And you don't have to use the words bullying because I think that has been overused so much. I agree. Are you feeling like your friends maybe are putting pressures on you that make you uncomfortable? Tell them what is bullying. Talk to them about that. And I think
because I don't know if we do know what bullying is anymore, do we, Desiree?
Right.
I mean, it happens. It's so insidious. It's everywhere.
Absolutely.
And on so many different levels at all different age groups, mine included.
It's true.
Believe it or not.
Absolutely.
And I think that really struck a chord with me, what you just said, though, that bring the parents into the fold. And, if your child had diabetes, you would want to talk about different kinds of therapies and how we're going to deal with this.
Bingo.
And let's work together to make your child have the best life that they possibly can. Let's bring child X into the conversation and empower them and not feel like a victim of diabetes. Why can't it be the same for mental health?
Absolutely. And I dare say, I think if I was a betting person, that if you did that and you had those conversations like you would, that's a perfect example. The same way you would have those conversations about diabetes with the family, if you did that with mental health, you would see a reduction in suicide.
Yeah. Because I mean, it's rampant, and I mean, it's a changing world. And I think we could talk for 3 hours about what's potentially happening to our kids with these phones and the constant deluge of information and negative comments and social media and pressure and everything. It's a whole new world out there for our kids in this mental landscape, as well as for adults. So I think it's time that we maybe kind of like catch up with that, because I feel like as mental health goes, we are not keeping current with the way technology is.
I agree. We are behind.
Yes.
For sure.
Yeah.
And I think that's kind of a good segue too. And, I work with adolescents mostly, some small children, but mostly adolescents. And I have 4 kids, and, I just sit and I'm like, gosh, when I was this age, I this wasn't going on, but, and I think the staggering thing, and, this just, it bothers me all the time. It bothers me every day at work. Suicide, it's the 11th leading cause of death in this country. For children ages 10 to spanning to 34 years of life. But for children, it is the 2nd leading cause of death, only 2nd to traumatic injury, which most of the time involves other behavioral health disorders such as substance use in our adolescent population. And in my personal opinion, and I would argue really hard with anybody who wants to fight me, this is preventable. This is 100% preventable.
I agree.
So, this is not okay. It's completely unacceptable.
And it's so much more than, when you say preventable, it's so much more than we'll get them into an inpatient psychiatric setting, get them into see a psychiatrist. There's so many other things that need to be done at the same time. Yeah. And it 100% involves a support system and family. And the only way you do that, especially when you run cultural differences that don't recognize this, right? Yeah. You run into that stigma. The only way to do it is to break the stigma. And the only way to break the stigma is to keep having those conversations.
Yeah, I couldn't agree with you more on that, actually, that it seems like they've never even, 60% of them who die from suicide have never even received mental health treatment. So how much could we bring that number down by a simple intervention?
Right.
Absolutely. Yeah, just at the right time, right place. I mean,
because it's still looked at as very shameful, unfortunately, which is
which is devastating to me. I mean, where I grew up, it was very isolated, and there was a lot of suicide. I can count them on 2 hands off the top of my head. In family, academics, professionally, classmates. It's just. It's shocking. It's shocking.
And I think
each one's a different reason.
Yeah, well, I think it goes to show that it really doesn't discriminate. Behavioral health doesn't discriminate.
Right.
Yeah, we could talk about social determinants of health all day if you guys want to. I'm sure they put people at risk, but unlike other diseases, and I just had this conversation the other night with somebody near and dear to me. We were talking about alcoholism. And I said, it is a disease, just like hypertension.
Absolutely.
And or cancer, and if you don't recognize that and realize that it's a disease that needs attention and consistency and treatment, and, it's very difficult to overcome stuff like this. But I think we don't even, I feel like even in our healthcare space and all this rhetoric that's shoved down our throats all day, every day, I still feel like we don't, as a community, really recognize behavioral health diagnoses as a disease.
100%. I was just going to say that. I can remember having to discharge somebody or have my care managers, and this is years ago, so it's gotten a little bit better. But after 3 days of inpatient, 3 days of inpatient, like that was their allowance from the insurance, and that speaks volumes. Like, it's right there how you feel and how you view mental health. But it's the fastest killer right now
Yeah.
in our country. So
I did an interesting, which, one day when I have some time, I'm going to write it up. But I started seeing, I was working in the South Bronx in a very underserved population, but my moms, after they delivered their babies, were telling the pediatrician how depressed they were. They didn't do anything about it. So we started administering the Edinburgh in all of our pediatric offices. The Edinburgh is postpartum depression scale. Typically, it's administered by OB providers 6 weeks after women deliver, but we were catching them in the peds office at 2 weeks or 10 days. And they were telling pediatricians, I'm overwhelmed. And we got them help. And we saw statistically significant results from that.
That's
And
amazing.
again, I should write it up and publish it because it's so important. But I think we have to start thinking differently. That was just an idea when one of my pediatricians was actually complaining to me saying, this is ridiculous. These women are always telling me about their postpartum depression, and I'm not sure what to do with it because I'm letting them leave my office with an infant. And I said, well, I think that we have a responsibility to do something about it. And sorry, you're a pediatrician.
Right.
You signed up.
It almost feels
Welcome.
like it's tertiary care.
Yeah. I mean,
But that's how we're handling it rather than as a primary.
it's not a primary
Absolutely.
concern.
Yeah.
absolutely.
Yeah, that's. Ooh.
Well, I'm happy to say not where I work. They are at the forefront. I am among some serious contenders in the behavioral health space.
Oh,
So,
we're so grateful that
That's why
you
I'm
made the
there.
time for us today.
oh, thank you.
But I mean, even in the workplace as well, a study from the National Academy of Medicine found that between 35 and 54% of nurses and physicians show signs of burnout. And the burnout doubles the risk for depression and suicide. If we want to protect our providers, hospitals can't just talk wellness. They've got to back it up with some staffing support and mental health resources and peer programs even.
Yep, absolutely.
Yeah. And I think I found a picture of us.
Oh,
You're
you
going to
did?
die.
Oh, gosh.
But I remember this day, and it was an awful
I
day.
saw this picture.
This was an awful day. And you and I were working, and I don't know, go down.
Is this St.
That
Joseph's?
is it. Yep. And I don't know how many days we had been there. And our staff was literally, this is during COVID. Our staff was at the end of their ropes, and we both kind of talked about it. We saw it. And I don't know where the hell you came up with a microphone and a boombox from 1989, but you did.
And my cheerleading
And
pom
cheerleading
poms.
pom-poms.
That was
And
the
we
icing on the cake.
made a sign,
Oh my god!
and
that's
we
great.
strolled through that hospital amongst all that devastation, and we
We did.
sang to
Sang?
our nurses. We danced. I
Tina
have video
Turner.
footage.
Tina
Wait, you
Yeah.
guys sing?
They did.
We
no,
did. Well,
I think not, but
we
they did do it.
Oh
And,
no!
you
do you
know,
actually have video?
I have video of us
Oh my
doing
gosh,
this,
This
and
is hysterical.
so it was like we were at the end of our ropes, you and
Yeah.
I, but we saw our staff, and what the hell are we going to do? Take another pizza?
Right.
Because that was getting old. So this is what we did. It was the stupidest thing ever, but people smiled.
It's peer support, though.
They
still talk about
that.
this.
It's that bond that you get with the people that you're on the floor with,
Yeah.
and
Oh, they were
you really-
so appreciative.
you have
Yeah.
to take responsibility for everybody. The guys emptying the garbage cans. You have to be aware that we're all feeling the same energy in the air.
Yeah.
Just because they're not the ones that are losing, that their patient, they actually are.
yeah.
And it hurts.
Yeah. We went through some
Stuff.
tough time. Yeah. That was
Aw.
amazing.
And I think, and that kind of brings me to, sure, we were giving them food every day.
Right.
People were so generous with food. There was so much food.
The community was great. Yeah.
But we always, as nurses, you guys know, we always say we don't want another freaking pizza.
Right.
And I think you and I that day saw that.
Yep.
And we were like, of course we're going to feed them, but something else has to give around here. So
yeah.
what can we do that is actually meaningful? Because pizza is not the answer.
Mhm. Mhm.
you
Well, listen,
know.
when I was in the hospital recently, I was going to tell you that I was sitting there, and when the food trucks were outside, all the nurses that were walking around were very excited about their food truck vouchers to go outside. So
No. They
That's a
were
whole other thing.
excited about the fact that they were getting off the unit. The food
Okay,
truck
fair,
is kind
fair.
of cool, but
Because
you
they
know.
opened the cage door and let everybody
that
out.
was
That's
it. Was
why
like, oh,
they
did
opened.
you go outside for lunch? I hear them all whispering, and they're
Yeah.
making sure everybody got out.
Yeah, exactly.
The
It was-
shock color didn't activate when you breached the perimeter.
Right, yeah.
Like you were free for 5 minutes.
Yeah.
5 minutes.
Yeah.
Yeah.
So
I think we can do more. Like I recently just presented this to my senior leadership, and it was being tossed around the HR department, offering mental health days.
yeah.
You know, especially after a postvention is triggered. Not every incident requires a postvention, but as a leader on the unit, if you notice like your staff really is taking it hard, or it's a situation that any normal person would feel something from this. You cannot just compartmentalize this and walk away, but they look kind of stoic right now, and they look like, you know, that they're numb.
Yeah.
And if you're recognizing that in your staff, they need to be able to take a mental health day, not one of their vacation days, not one of their personal days, but an actual mental health day. And I think that that's another thing that the Department of Labor needs to get, you know, behind, and we need to advocate. So I happen to have a really large union in New York.
Yes, you do.
So they're super present at all of these, you know, legislative meetings, and hopefully one day this gets in front of them. But I'm definitely a cheerleader for that.
What about cops? You know, something bad happens and bad things happen in your. Do you guys get offered? You know what? Don't come in tonight or don't come in tomorrow. Take a day.
Officially, no. I mean, you know, no. We fill out a form.
A form.
Yeah, we
A
fill out a form.
form.
Essentially,
A form.
the check boxes. It's the liability form that, you know, it basically documents that we were involved in a traumatic incident. So should anything ever, wait, home mic sliding in behind me.
Oh my God.
Yeah, here we go.
That sounds a little.
Right.
Again,
Next
Mike.
topic, next
But it-
topic.
Stop.
Again, it's just a checkbox. That's all it
That's what
really
they
is.
all
We don't
say.
get. But before I turn it over to Mike, I did want to circle back to when you guys were talking about kids and the social media, and I have this idea, and obviously it's in the infancy stages in my brain, but there needs to be some kind of legislation in regards to social media. I know it's a hot topic with free speech and all this, and how you can't regulate. Children should not have access to social media, and so I have this idea where it's almost like you need, in order not to access the internet, obviously you can't limit that, but to have an actual account on a social media platform, you should be required to present some kind of an ID. Now obviously that would keep children away because they don't have IDs, so they wouldn't be able to create these accounts. And on top of that, I think everybody's screen name should be their real name. I think that would, you're no longer saying these things from anonymity. You're saying them as you. And if you want to say it, go ahead and say it. You want to, you know, pick on somebody, you want to call somebody something, you want to threaten somebody, you're going to be doing that as you. And I think that, I mean, again, and I know legally there's going to be people, you know, if you have spouses of domestic violence that don't want to use their real names, or if you have, you know, authors that operate under pseudonyms or something, like, I know there's going to be legal challenges somewhere, but I really think we need to keep our kids off these platforms. There's nothing good that's really coming from that. And again, access to the internet, different, but these social media things, because you guys are 100% right. I mean, so much damage can be done to these kids of that, and even just self-inflicted, you know, from the pressures that they feel to keep up with all these, and so it doesn't even necessarily have to be somebody from the outside picking on them. It just could be from everything that they're seeing. I'm developing at a different rate than these other people. Now, what does that say about me? And we need, so there's something, I don't know how I got to come up with a name for the bill first, and then I just got to get trashed for putting it out there. Mike, go ahead. I'm sorry. I didn't want to take your time.
No, he's absolutely
Watch
right.
that thing on Netflix with the parents, the catfish school, high school thing?
Oh my God.
It was
No,
a parent
I'm
that was
It's
doing it to her
catfish.
own child, to her
The
own
thing she
daughter.
was saying to
Can I
her
have headphones?
daughter,
like bullying her own child on social media.
but protect like anonymously.
And
Oh,
you had to see the things that she
Oh.
told her own child, you should go kill yourself.
Yeah. Yeah. Oh,
It's called
you
the
got
high school catfish something.
catfish something on Netflix,
Yeah.
and it is
Dawn?
shocking.
oh.
And the mother is just so like, yeah, it was me. What in the hell?
And they were blaming all the other students, and they got pulled in. So then there was all
Again,
the psychological trauma that goes
the
with
mother
that for other kids
had
that didn't have
severe
anything to do
mental
with it.
problems,
Yes.
clearly,
mental illness,
that
for
was
sure.
not being addressed. Because when you watch it, and I know you will, you will say that woman is clearly not well mentally, right?
Right.
So although she inflicted her child, where was our stop to, identify that she's having mental problems?
Right.
You know what I mean?
Absolutely.
We
Absolutely.
can say oh, that was awful. But a normal in the head person doesn't do that to their child.
Right. She
Right.
was definitely
And I'm
having
not giving her
challenges. Yep.
permission. I'm saying that, to just condemn her without diagnosing what the
Yep.
hell is wrong with her
Yep.
is one of the problems that you're just kind of brushing it off like, oh, well, whatever. She's a horrible person. But is she okay?
Right.
Well, I wouldn't brush it off, but I would say it would be my secondary or maybe third or fifth concern, because it's the innocents, the kids who, and if you watch it, it's like, well, this is what these kids do. And then as you're starting to watch it a little bit more, you're like, something's not right here.
And it was so sustained.
Yeah,
it went
was like
on for so long.
years.
The
Yes,
high school
nuts.
catfish.
Yes.
Yeah.
Thank you, Michael Freed. See,
Ugh.
he's good for something. Research.
I wasn't done. Don't see, now you just gave me trauma by cutting my microphone
I
off.
was just
need
going
to
to say,
speak.
though, you watch that, right? And you be careful, though, because that's what causes secondary trauma.
Mhm.
You
It
watch
is.
things that then you can't get out of your mind.
Yeah.
So be protective of things you watch, too.
Of your
if
own
you're-
mental.
Yeah, like, and your children at impressionable ages, we have to be cautious of things we have to protect their mind, right? Because there's
Wow.
things that we watch that we just can't, you start perseverating about and you start thinking about, and it causes anxiety and worry. And so be cautious when we're watching things that pique our interest. Is this good for me? Is this something that I could do without watching?
And
I know about this now. I will never watch that.
I'll watch it every time. I love that
So
stuff.
funny.
But
Okay.
it does open up the conversation about kids' brains, or the physical brain itself, especially in males, I believe doesn't stop growing. Ashley, is it until they're 24?
Yeah.
So I mean, the brain is still growing.
Yep.
How can we introduce information that's for a fully grown brain to a brain that is still growing and expect them to be able to make these decisions?
Right.
It's just, I feel like a lot of variables are not being considered when it does come to protecting our own mental health, which opens a whole conversation that I'm dying to do an episode on.
If I could just go back real quick, because I'm going to get off the mic, back to what you were asking about the police and stuff like that.
Yeah.
It's never going to be the cop who sees the traumatic thing coming forward and saying, I need a mental health day. It will never happen, no matter how many strides we take forward, because then you have to worry about losing your firearm, being put in a rubber gun squad, being judged. It has to come from higher up. They have to identify the PTSD related or trauma related incidents, and it has to be a mandatory thing. Like if you get in a shooting, you have to go see a psychiatrist or a psychologist and be cleared to go back to work.
Right.
It should be no different if it's some other sort of traumatic. Now, it is true, cops could see 800 in their career. I probably forgot more than I can remember, but if it's something of that magnitude, it has to come from above, and it has to be you must take one mandatory mental health day, kind of like what you were saying when you go to the school and you have to go to each place and collect each one, so there's no stigma if one person only walks over to the mental health table.
Right.
Every cop, every time, but that's going to go into finances, manpower, and then it goes into prioritizing, and like most times that's going to be lower on the priority list, like when you were 20 years old and saw what you saw.
Yeah.
You know, things change, but a lot of things kind of stay the same. And most cops are not going to admit that there's something wrong. And the peer pressure, the peer groups work, because we did one with our charity where we have a doctor in New York. I can't remember his name now. It's going to kill me not to remember his name, but he's high in the field of suicides and mental health awareness. And he would teach courses, and we would just get cops from all over the place, have them come sit in the classroom, give them some coffee and donuts, and he would teach us the way you're supposed to identify and the things you're supposed to see. And I learned that everything I thought I was doing right, 100% was wrong. Because inside of the charity or inside of the brotherhood or sisterhood, a lot of times that's where guys and gals will go, not to the administration, not to the higher ups, to their brothers and sisters, the people that, because when I was in a dark place many, many years ago, I had a guy come to me who I couldn't stand. I hated him. He hated me. No, it wasn't you. But I was in a pretty crappy place and, you know, going down a really dark path where he had been before. And he just stopped me in the locker room or in the hallway and said, "Hey, you okay?" I was like, "Get out, you know, what do you want?" And he's like, "No, dude, are you all right?" And I'm like, "What are you talking about?" He goes, "I can see it. I know."
Yeah.
And then we had a conversation, a deep one, and it got me on the path to go in the right direction. Because I feel like the pressure that you're talking about is almost like a teapot, right? When the pressure is building and the pressure is building and the pressure is building, and you release the top and you let some of that pressure out, that one time that you let the pressure out might be the time where you were going to explode or make that bad mistake. So that one conversation could be the difference in turning things around. Talking is very important, and it shouldn't just be clinical. It could be a friend. It could be, you got to learn to put aside, cops especially, because everybody's machismo and doesn't want to admit that there's something wrong, but the brain is like every other muscle in the body. It gets trauma, it gets hurt, and it needs to be, you know, to be helped. So I'm glad we're doing this episode today. And I encourage anybody who's listening and watching today, if you do have an issue or there's something going on, reach out to somebody, a friend. Or sometimes it's, you know, if it's not a professional, it could be a peripheral friend, somebody who, because sometimes you don't want the people close to you knowing. But there's always somebody, there should be always someone in your life or one of those hotlines or somewhere where you can call and maybe just release the pressure just a little bit and get to tomorrow. And then get to the next day. And then you string together 7 or 8 good days where you had, you know, 30 bad days. And now, like you said, 3 o'clock in the morning, 3 o'clock in the afternoon, you start to look at the world a little different. And then maybe that's the key to.
But it's just like alcoholism. You get that one day in, then you go and build on that to the second day, to the third, to the fourth, and you just keep moving forward. And I think a lot of times, Mike, you know, it takes one to know one. You know, I can listen to what a firefighter would have to tell me, but I don't know. I'm not one, but I can listen to what Ashley has to say, and I can relate to that. You know, so I think a lot of times within your peer group, it is really you're going to find somebody there that, you know, it might be the least expected person, but it's like you said, it's just the difference between do you blow or do you not blow?
And it's even scary for the person that wants to help, because I know this for myself. I've helped, you know, I'm a mental patient. I'm a whack job. I mean, clearly, but I've helped a few people along the way and had conversations with them where I'm not tooting my own horn. He knows this, but I'll get calls a certain time of the year from different people to say, "Hey man, thanks a lot. This is another Christmas in the books with my kids. And if you didn't tell me the things that you told me, then I probably wouldn't be here today." But I've also lost a couple of people where I was helping them and thought I might have gotten them to a place where they were okay. And then, so it's always scary for the person that wants to help too.
It is.
What if I say the wrong thing?
Yeah.
But I would rather say the wrong thing than not say
I don't think that
anything at all.
That's the wrong thing to do, is say nothing at all.
Right. Well, it's a scary. It's just scary all the way around. The stigma is on both sides. It's, you know, and then you're worried about, and then sometimes you worry about. I'm just rambling now because this is a topic that's dear to me. But you worry about how your friend or acquaintance or whatever is going to perceive you by you maybe starting that conversation, and then they might get defensive or insulted. Even if it's true, it doesn't matter. They just feel like, well, what makes them think they could be the one to tell me A, B, C, D? But if you care about somebody and you love someone, you got to do that.
Well, and
Please.
I think like that's interesting too, because I often think that it's more the peer who's worried about what they're going to think. And, there's research out there that tells us that sometimes it's just a question, and it's actually okay to pointedly say, Tanya, are you thinking about killing yourself?
Right.
Oh, of course.
Right.
Like, you don't need to beat around the bush.
Right.
It is a direct question. And the response that's usually given is not one of, how dare you ask me that?
Right.
It's usually something different. And I think, Mike, you kind of struck something in me, and I believe so much in peer support. And I think, we talk about alcoholism a lot.
Yeah.
I work in it a lot. The only proven treatment modality for alcoholism is a 12-step program.
Yeah.
And it is that truly, truly sustains sobriety over time. And it's a peer group.
It's a
It is.
peer
It's a
group.
peer
It's,
program.
it's a certain amount
It
of
is a
responsibility
peer
within
program
that peer program.
with no professionals involved. There may be a professional sitting in the room because they have a problem.
That's
Absolutely.
right.
But, and I mean, Desiree, what do you say to that? Like, Mike's worried that he's going to offend somebody, but he sees something wrong. What's he say?
So here's the thing. Saying nothing is the wrong thing to do, right? So a lot of people do say nothing. Think of any situation where somebody's hurting. If you don't know what to say, a lot of people will close, and then they feel even more alone, right? And so you're like, I didn't say anything because I didn't know what to say. I didn't want to say anything that set them off. They seem to be okay. It's okay to say, look, I'm here to listen. I may not have the answers, but I'm here.
Yep.
And that in itself is comforting. And so that's enough. We're not going to have, when someone dies, we always would like to say, they're in a better place. And we've all been told, we've read a million things. That's not comforting. That's not something they want to hear, that they're in a better place. Maybe that's not their belief. A better place is with me here on earth, right? So rather than trying to find the right answer to make everything better, because you're not going to, it could be multifactorial why they're feeling the way they're feeling. You're not going to have the answers to everything, and you're not going to go down that rabbit hole with them, because then you're better than they are. And it could lend itself to more trauma for them. Just simply say, I'm going to sit with you. I'm here to listen in a non-judgmental way. I may not have the right answers, but I am here.
Yeah.
And that's,
it could be something as banal as a text.
Yeah.
I care.
Right.
Yep.
Are you well?
I'm
Because I
checking in
care.
on you. I'm checking in on you.
Yeah. It's
Right.
just, and I mean, that takes no effort on your part,
Right.
but it makes all the difference, because it lets at least one person cared,
Right.
Yeah.
And I hate to bring optics into it, but hindsight is 2020. So we want to be a little more proactive with checking in on people when we're
Absolutely.
concerned. Yeah. Or just, do you care?
Yeah.
Because sometimes that's a healthy outlet for the person reaching out to say, you know what, I actually care.
Mm-hmm.
Yeah.
Yeah.
Well, and the other day, I think like I was having a bad day for 700 reasons, whatever. And I sent a text that I needed to send, and the person responded to me, and the response was, I was just thinking about you. I was happy immediately. Everything that was pissing me off, work related, family related, other things, that simple. I was just thinking about you. And I took note of it, because I think about like the people I work with and how they feel. And I'm like, okay, I was feeling pretty funky just for like, the last hour. And simply me sending a text that needed to be sent and to receive not the answer to the question I posed, but I was just thinking about you. It was
Powerful.
I needed that.
Mhm.
And so I needed that because I was having a bad day. Imagine somebody who's really struggling. And,
Right.
Yeah.
I think resources. So I think 988, and I don't think very many people know that number. And it is astonishing to me. That is the suicide crisis hotline, and anybody anywhere can call it anytime.
Yeah.
There is always somebody to answer.
Mhm.
They have extra, veterans, they have an avenue for them to press whatever number to get help for themselves.
Yeah.
So, what other resources are out there for folks? How can they right now, no matter if it's 3:00 in the morning, where do they get the help?
Exactly what you said.
Yeah.
It's not that it's there for that reason. There is someone at all times at that number. And you're right, it's not, I think, socialized enough.
No.
I'm seeing it now on both. I actually saw it coming here.
Okay.
I saw a couple of billboards, but I do think there should be more commercials around it. There should be more funding toward it, so that we can market it more, so that people do know that.
How about on social media, instead of showing me an advertisement for some crappy clothing company, we throw a few more of those in there?
Right. Yeah. Right. But here's the thing. There's all these thoughts, but who owns that? There's not an organization to like take that responsibility, right? Like, who is that? Is that the Facebook gods are gonna do that? Like, who is gonna do that, right? Because it's not
nurses, because we're advocates.
That's right.
Like,
if everyone
we
does
are.
it, yeah.
We are.
We
going to
actually
do it
have
because
a
nobody
number
else is
of
doing it.
resources here, which we are going to post to the website and on our social media. Because there are resources out there, Ashley, even for nurses, like the ANA's Wellbeing Initiative and peer support networks that really help us process the burnout and prevent isolation. And I think that the bottom line here is, folks, suicide is typically preventable. When we talk openly and workplaces are stepping up, and when we check in each other, we do save lives. Yeah.
So I think, and for the two M's and behind the door, Mike, Mo, where can our first responders go? What's out there for them? In blue too. Yeah.
There's Cop to Cop. There's also Cop Line. This is just speaking for me. I'm not endorsing anything, but I said Cop Line. I think is a better way to go. They're a charity, and Cop to Cop is funded. So there's the perception from the inside that they answer to people. So I think they're trusted a little bit less. And that might be unfair. I own that.
Yeah.
I'm not, I could be speaking way out of school, but
No, we're asking for your opinion.
yeah, Cop Line is a good one. I'll have what we'll do, because you guys are coming right up. You're a little over the hour mark. Get up and stretch your legs. But what we'll do is all the resources that you were listing, we'll post those up in the comments, and I'll put the links to the websites for everything that you had there, and then also for Cop Line in the comments. I know Dawn's looking up a bunch of other ones too. We'll put as many as we can up in the comments, and then we'll circle back and pick up where we left off.
I think before we go,
wait, Mike, hold on, wait.
Mike's coming back, and then
All
we're
right,
gonna play a
serious.
little game.
All right,
He's always sneaking up
Something
from
else that can have
behind.
the headphones.
You can have it. Yes,
It's weird not having my beautiful face on the
No.
camera when I'm
Oh, honey,
speaking,
we'll
but-
bring you out.
Oh, okay. So I think also too, besides the official ways, is if you're in a police department, maybe you go to your union guy or somebody that's been down the road before, because there are avenues that you can take where there's people out there, good people who were in the position before and then retired and went on to like do it in private practice and stuff.
Yeah.
And I've done this for a few people where they'll take them without their insurance. They'll do anything they can to work it out, to get the person the help they need first, and worry about all the other stuff later on, because that is the big thing. You're always worried about the job finding out or the job knowing what's going on. And it's crazy, right? Because you're in a crisis and you're having all these crazy thoughts. And then you go to worry about, well, I'm not going to have my gun, or someone's going to look at me in a weird way, when the other side of that coin is I'm not going to be here anymore.
God.
If you're having those kind of thoughts. And a lot of times when you find cops who do that, take their own lives, they chose that rather than getting the help. And that tells you all you need to know as far as how far we've come and how much further we need to go.
Yeah.
So I always encourage, talk to yourself in the mirror, talk to the guy shining your shoes, talk to the bus driver, talk to anybody who will listen. Talking is important because it's a way to release some of that stress, and that makes you, even if it's like 10% more clearing of your thought, that 10% might be the 10% that says don't do that, give it another day or give it a little time. Talk.
Well, it's an accumulation of unresolved thoughts that we just don't seem to have time to process properly. in contemporary society. And yeah, just that one extra can be the tipping point.
Yeah.
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 I think we need a little tension breaker, do we, Ashley?
Yeah. Before
Yeah.
we take a break, let's take a break.
Okay.
Oh,
All right,
wait,
what do you have in mind?
Well, I have a little cocktail planned.
Oh boy.
I have a little game for the police boys.
Oh
Yeah.
boy.
Oh, yeah.
Yeah, you get
Yeah.
it. You're gonna
Doing
get it
their
back.
shows.
You are gonna
Remember
get
when they
it
first
back.
came on
You're
Code
not-
Lavender and it was all serious and they were going to be doing all this stuff, and then they did like 1 or 2 shows here, and now there's like, what was the other drink they had last week?
Oh,
We had the slippery nipples.
Slippery nipples,
Slippery, yeah.
and now there's
Clearly, they
some
were-
sort of like needles out there with some sort of foreign substance in them. I don't know what's going on.
All right, so you guys put us on the spot. We have some nurses we want you to take a look at. And you're gonna
Yeah.
need to make
Okay.
a-
Oh, here.
Yeah. You're gonna
Okay,
need to
this
make a
segment-
decision.
I'll play a game.
Okay,
And I
boys.
see you, Mike Freed. You're up.
Boys, boys, anybody that's watching, we're going to play a little game called Handcuff. Hot,
Oh.
steamy night. Marry or throw in the slammer. All right, boys,
Oh,
who's
boy.
first?
Married or thrown in the slammer?
Hot steamy night.
We've got
Handcuff.
handcuff, hot, steamy night, marry or throw in the slammer, and that means lock them up and throw away the key.
Okay.
All right. Who goes first here?
I listen. Everybody watching, let's go. I want everybody playing.
All right. Well.
There's Jackie in the upper left-hand corner.
Yeah.
She's got all the good drugs.
No, that's Soprano. What's her name? What was it?
No, but
Yeah, that's Nurse
that's
Jackie.
Carmela-
Nurse Jackie.
No,
Carmela
they're-
Soprano.
They're all
No, that's
nurses.
Nurse Jackie.
Carmela
Damn it,
Soprano
it's Nurse Jackie.
to the slammer.
No.
No. What do you mean?
What are the 4 choices? Tell me
Don't
again.
you dare take her off the floor.
What are the 4 choices? One more time.
We have handcuff,
Handcuff.
hot, steamy night, marry or throw in the slammer.
I told you.
I'm gonna marry her because she's got the good drugs.
All right.
Yeah.
Yeah.
And she will share with me. And
All
then who's the one in the bot right under her? What's that nurse?
Oh, she's from Emergency.
Emergency.
Yeah.
Trixie.
Remember that show?
Let's see.
Wow. Yeah.
Squad 51, Squad 51. See the man. Of course
Yes.
we will. Go. Timeout 1020.
No, that wasn't it. No,
I'm
it was
Jesus
I'm gonna-
Christ.
I'm
that's
gonna-
so many
I'll-
milligrams of
I'll have a hot
lactated
steamy
ringing.
night with her because it's gonna be like 70s sex.
Oh,
Yeah, 'cause
Oh,
that's when that
nice.
show was around. And
So
She was a jazz singer
free love,
too.
man. It's free
so
love.
you're to a little.
Julie London, she was. Oh my
Yeah, a
god.
little. Down
Yeah.
Yep.
Yeah, but no. So, all right.
Yeah,
go
that
ahead.
one.
I
All right,
don't know
number
how much
7.
whistling
Now, what's
they'll
the
do.
top right? Who's that? That's from MASH, right?
MASH. Yeah.
What are you gonna do?
That's Honeycutt, Nurse Honeycutt.
Yeah.
Don't ever take me to
Good.
fucking trivia because I
You
will
are
win all the things.
good.
All right,
You
come
are
on.
I'm gonna
win.
throw her in jail. The cuff her. I'm gonna cuff her.
Cuff her.
And then what's the
Okay.
last choice that I have? What's the thing that's left? Hot steamy night.
Yeah.
I'm alone with you. Remember that song?
I-
I
Hot
think I'm
steamy
alone.
night.
now.
Oh,
I'm
no,
gonna
you
take
were
the hot
having
steamy
fun
night.
with her.
Where's she from?
No. You wanted a hot steamy night
Yeah.
with Trixie.
Well,
So you're gonna marry the other one.
You're gonna marry the girl. I don't
just
even
because
know.
I marry her does not mean I cannot have hot steamy nights with her
Oh,
as well.
here we go.
Right?
True.
All
I'm
right.
gonna
So,
marry. Where's she from though? That bottom girl on the right.
I don't know.
Oh,
It's not Grey's Anatomy.
no, it's the newer one.
Chicago
Hope?
Med. No.
No,
I don't know.
Oh no, not
Oh.
not the Pit. Is that the Pit?
not
No,
the pit. In
no.
between those two, between Chicago.
I really
Med
wish you
and
would
the
have went for a few
ER?
ER nurses from the TV show ER, maybe, or the Pit. There's a
Grey's
few on there I
Anatomy?
like.
Pit. Mm-mm.
No.
All right,
not
but I
Grace.
said my piece.
all right,
Okay,
well,
John.
thank
I'm
God
sorry,
for God
Mo?
for that. All right. So you're saying that Nurse
That's Nurse
Jackie's got the
Jackie.
good drugs. All right. So
Yes.
maybe I don't throw her in a slammer. Maybe I handcuff her then.
She goes in the thing and she opens up the pill dispenser, so she gets all the good stuff, and
Yeah.
then she takes.
You're gonna
the-
take her off the streets.
what?
You're gonna.
Well, what
take
if I
her-
no? But if I handcuff her and she's got the good drugs, then
But then she can't go get.
Okay,
any more
I don't know what
drugs.
happens in a police car after you get handcuffed. I don't know what you guys do,
Well, I
but
wanna
to the
know what
best
you
of my
do.
You want to know
All
what happens after the cuffs go on? You go in a police car.
all right. All right.
Well,
Sorry. So
I know
I'm throwing
what-
her in handcuffs.
look.
Yes,
This
hold
is right
on.
ready for that.
And that is Jada Pinkett Smith, obviously, but from Hawthorne. That was the show.
Oh,
Hawthorne.
Oh,
okay,
I had
okay.
to Google it. I
Okay,
had to.
okay.
Wait, that's the one that's married. to
Keep
Wilson?
your hand,
Oh,
my
she's going to
wife's
jail. Throw her
name.
in jail.
Oh, you can't do
No,
that.
I didn't know that that's the one with the.
You
No.
can't.
Now she's going to jail because of her
Alopecia.
husband.
Yeah, that's alopecia.
So what? What's wrong with
Alopecia.
that?
Throw her in jail.
You're gonna throw her in jail because she's got alopecia? What in the wide world of?
Oh,
the way she
no.
looked at Chris Rock and all that stuff
It's
that
not.
happened.
It wasn't
No.
her.
I
It
opened
was.
quite a can of worms, didn't I?
It wasn't her attitude. It was.
Oh my
It
God.
was her
Wilson
husband's.
overcompensates because he has
Girls,
PTSD.
girls, girls.
I'm sorry. I'm
Enough.
focusing.
Come
Okay.
on.
Girl.
Nurse Jackie's getting handcuffed. throwing the 70s broad in the slammer.
Which one?
The one from Emergency.
Why?
She's going in the slammer. I'm marrying the mash broad because piggybacking off of our earlier show, she's going to be able, she can do life-saving shit, and she could save, well, no, if she was a Marine, she wouldn't be saving legs. Only the Army guy would be saving the legs. They were Army, right. So she's going to save limbs, so we're good.
Do you know the signia of MASH? What was their 4-digit number?
4077.
What'd you say?
4077.
She got it. Okay, and then I'm going to have a hot steamy night with alopecia.
All right.
There it is. Now, Dawn, you're up.
Oh, I don't even know any of these.
Oh, these are girls. You can't.
It's 2025.
Oh,
You can't say that.
I usually do it with the
Love
women.
it.
I don't care.
That's the next segment. Now we're going to break.
I'm going to break. We were talking about a resource. I forgot one of the charities that one of our buddies owns and runs. Danny DeValle owns Moment of Silence.
Oh, momentofsilence.org.
He actually hosts free events, and like anything else, he knows how to get cops to come out to events. You just offer free food, and you offer free food, and the cops are going to show up. But he'll have they share. They'll have, it's like an open mic, and people will give their testimonials. People that have been on that edge. He has a lot of powerful events. Links already up there.
The link's in the comment.
Momentofsilence.org. And again, same thing, charity driven. So yeah. All right.
Nice.
Take a break, stretch your legs.
All right.
views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent.
All right, we're back. Had a little bio break. We're gonna do some fun stuff. That was
Bio break.
a bio break.
Like
This-
biohazard.
Yeah, biological breaks.
Okay.
And we are back, and that was a hard conversation.
It was.
For sure, and we had a lot more hard conversation. Mike Freed, I did see your comment that there was a retired NYPD officer that died at the hands of suicide last week, and my heart goes out to his loved ones, and just it's just another example that it's there, but we're going to try to make it a little more light. We have another serious topic. We're going to get into sexual health awareness. But first, Tanya has decided we're going to drink ourselves a Code Blue today.
Yes. So,
I
look, I know what I'm doing here. We're good. All right. So, what we
Yep.
need to do is, and I'm going to pour them light. Don't worry.
Okay.
We're going to do a little bit of vodka.
Mm-hmm.
I'm not sure how many people we have here. Do we have 6?
I don't know, but
Yes.
you're
Okay.
planning like we do.
That's all right.
All right.
Do or don't. All right. Then we're going to do a little bit of orange liqueur.
Yeah, that was a light pour. Like,
Listen, this is the only Code Blue you're getting this week because it's going to happen right now if she's
Listen,
making drinks.
Baby. I am pouring light.
Code Blue is the cardiac arrest. So
Okay.
we're
This won't hurt your heart at all.
okay. What is
This
that you just?
Oh, I'm
did?
sorry. This was liqueur, orange
Orange
liqueur.
liqueur. Okay.
Now we're going to do the color, which is our blue curacao.
Okay.
We just need a little bit of that. And that's mostly sugar, so just calm your tits. We're
My
good.
diabetes rate.
you got to move the bottles out of the way so we can see the glasses.
Okay, I'm coming. Hold on.
Yeah, your presentation's off, man.
Big time.
Fired.
Oh,
You're not gonna
now
hear-
we can see the.
you're
There
not
you
gonna
go.
Be like the celebrity bartender. It's not happening.
Okay.
Next.
Next.
Stick to nursing.
I am.
All right.
That's what they said about opticianry. And look at me now.
All right.
We're going to do a little bit of Sprite,
All right.
7-Up, whatever. I can hear you back there. Just so you know. That one will be mine. Okay.
All right.
And then we're going to do just a little bit of.
Cranberry.
It says to put some
This
cranberry
is for the
in. But,
kidneys.
I don't know. Whatever. Yeah, sure. It's therapeutic now.
Therapeutic. Oh, and it's tie-dyed. I love it.
Oops. Someone's getting a dark one. Now, this is my part of the drink recipe. I made just a little bit extra because I am extra. And we're going to do a little bit of cranberry juice. Oh, we're missing one. That's okay. Again, not a problem. I'll take the weak soldier. And here we are. Bon appetit.
All right. So cheers.
Oh.
Cheers to all the work that everybody's doing, even when we have to sit around and talk about this kind of stuff and how important it
Definitely.
is. And
All right, I'm
what
gonna go
am I
deliver it.
supposed to do with the injectable?
Oh, inject.
I mean, this is parentero
You
liquor.
know, you really need me to tell you what to do. Stick it in. That's what
Thank
nurses do.
All right. So, this is getting everywhere. She seriously cannot hack it as a bartender. You're fired. Like,
Where do we inject this? In the rectum? Or what is this?
so if you inject alcohol directly into your rectum, I'm going to give you. That's bad. You're going to be
All right.
unable to drive.
And I'm
All
going to
right.
put a little bit of this in mine.
Okay. Are we shooting it into our drink?
Yeah.
Okay.
Do it.
Excellent. This is so
Mike
exciting.
Mike is
Jesus
dying.
Mary, Joseph, this is not a light pour. This is
It is.
Can I-
No, it
Wait,
is.
wait, can we start?
Maybe
with
in
the
Canada
fridge?
this is a light pour. We're in the United
Oh
States
my
of
Lord.
America.
But it's
Chin
good.
chin.
Yeah. Cheers.
Skull.
All right.
Oh. Mm.
I don't know. It's pretty.
Oh, it tastes like
It's
candy.
All right. So, we're going to,
Woo!
before we get into our
David's the
sexual health, let's
Murgatroyd.
just
Calm down.
some of those nurses out there in the spotlight,
it's our nurses
they're
in
at
the
it
news.
again. And I think this is one of our favorite things to
Oh
do.
my
is
God,
Find
look.
some nurses in the news.
I can't tell you
um,
how much I love finding these stories.
Yeah. But I think more importantly, one of the things that hit me hard was Mississippi, good old Mississippi. We don't know anything about Mississippi, right? We don't hear anything, but they actually stood up and declared a public health emergency due to their infant and maternal mortality rates. And I applaud them for doing it.
Yeah.
I am sad for their statistics. I looked a lot into it, but they are truly going to stand up and try to provide better maternal child care to prevent these deaths that are truly preventable. So go state of Mississippi for kind of erasing the stigma and saying, yes, we're doing really poorly. We are killing women and children still in childbirth in this country at rates higher than any other country in the world. So Mississippi has amongst one of our highest in this country. So they're doing something, and they are calling it a public health emergency. So I love it.
Why do you think it's happening though, Ashley? I mean,
well, and we lecture about this a lot. I lived it. I'm from the South, so this is rural healthcare, and it's a crisis, and it's a crisis that we're not familiar with here in New York and New Jersey, because we have a hospital every 3 miles. You know what I mean? Like we have something. Sometimes these patients in these remote places have 3-hour drives to get to some kind of healthcare, and I'm not doing politics. We don't do politics on our show. But because of some of the abortion bans and things like that, a lot of obstetricians have left these states in that area of the country, and women have nobody to take care of them. Lack of prenatal care, poverty rates, all these social determinants of health are playing into this. And, Medicaid. And, I work for Medicaid. But they lose coverage 60 days after they give birth in Mississippi. And it's like that in many states. We know postpartum period is 6 months. 60 days isn't going to hack it. So, that's part of the problem. And then just their rate of chronic disease before they're pregnant, obesity, hypertension, all of the things. And, I have done so much work in this, and I'm going to say it here. I'm going to say it again. As my student, how many times I've said it to you, but there are racial disparities. Our healthcare system is systemically racist. We know this. And Black women are 3 times more likely to die from a pregnancy-associated complication than a white woman. And for infants, it's more than the disparity is larger than that in Black infants. So, I think we have to look at, and they have transportation challenges, right? And then they have 3 other kids at home, and they can't get to the doctor. And so there's all of these things going on, and this is the United States.
Yeah.
So
I mean, it's, at least I can applaud them for finally stepping in, and, hopefully we can get a spotlight on this problem, because this has gotten, those numbers are terrifying, Ashley. They really, truly are. And I hope that they get the resources allocated where they're really needed. Yeah. Okay. So I'm all covered in bubbles with the next one.
Oh, Jesus Christ.
Oh boy.
I am so excited. I've been waiting for this. I have been sitting on this one for a month.
Yes, you have. I've heard about this for a month.
I'm so excited. All right. This girl, I think she might be my spirit animal.
Wait. I'm looking at the graph. All right. All right, go ahead.
Listen.
Go ahead. I'm looking at the graphic. That's all right. I got to hear this.
A nursing student was arrested at Reedland Community Hospital after several patients filed complaints regarding inappropriate sponge baths. Witnesses allege that Darla Thornton, 22, displayed an unusual enthusiasm during patient hygiene routines. One elderly patient, Mr. Fitzpatrick, claimed Thornton spent an eternity cleaning his elbow. Dirty bitch.
Elbow?
Dirty
was that with a wink, or was that?
Listen. No, accompanied by what he described as thrilling and disturbing at the same time. They all say that to me too. Mr. Bubbles. Hospital staff became suspicious after noticing a significant increase in patient requests for sponge baths. I'm getting so excited.
The drink.
Listen, this is my life story. I have to tell you. You know, I can
Baths.
and look.
Yeah.
Oh my God, this is following me from poking eyes to. Security footage reportedly shows Thornton entering a room with a bucket overflowing with suds and a mischievous grin. I love her.
Oh,
I literally love her. Listen, I got to tell you, Darla, call me. Okay.
What course exactly is that?
Love her. Love her. She kept asking if I wanted extra bubbles, recounted Mrs. Gable, a recovering hip surgery patient. I mean, the temerity of her,
I know.
right? I mean, where do you get off? Thornton,
Apparently at the sponge baths. Apparently.
You know what? Listen, apparently it's at Reedland Community Hospital. Thornton, currently suspended from
verbal battery.
Farley Community College nursing program, faces multiple counts of misdemeanor battery and excessive
Oh, wow.
All right, that's enough.
yes.
Spongery.
Her attorney maintains her innocence, claiming she was merely providing a superior level of care. If I had a dime for every time, I'm telling you.
Yeah.
Look, you get
All right.
enthusiastic about your job, and what happens?
Right? Just
Yeah.
punish you. Right?
Sponge-worthy is sponge-worthy.
There you go.
That's right. That's the thing. Yeah, you know, I love Darla. Darla, call me. I'm not kidding. we got a future together, Darla.
Yeah.
I'll show you a thing or two.
Well, thank you for that. Was that your sex phone voice?
No, what do you
your,
mean?
Your reporter voice.
Oh, I get. You know, it drops a couple of timbers.
See, Dawn, I wish I had Chad's music in here now. I could have been playing it while you were talking.
I don't know if it would have been the same though. Because you need Chad's low voice.
Yeah, no, it definitely wouldn't have been the same.
Well,
All right. So it's Suicide Awareness and Prevention Month, but it's also Sexual Health Awareness Month. And this is also something that we don't talk about and we don't inform people. There's stigma here. It's not probably the topic of dinner, right? At your table. We all have kids, and it's about self-care and being well and protecting yourself and protecting others. You can't ignore your sexual health like you do your car lights. You know, we have to. So we have to talk about it. We have to educate people. There are a lot of misconceptions about sexual health in general. So I think, you know, it's good conversation to have.
listen, it's not a small problem. According to the CDC, nearly 1 in 5 people in the U.S. has an STI at any given time. That's about 68 million people. All right. Every year, there are 26 million new cases, and almost half are in people aged 15 to 24. What we were talking about earlier.
Actually, they're 25. That's
Right.
you know, to that's out there. A study, 30% they never had a real conversation with their doctor or their provider of any kind at all. So we are failing because we are the people with the ability to and, you know, people, there's that factor again. They don't want to tell us about what's going on. You know, it's not a comfortable conversation. And this is dangerous because it's dangerous to not treat it, to not address it, but it's also dangerous to other people.
Yeah. I mean, sexual health isn't just about infections or contraception. It's about relationships, consent, body image, and confidence.
Yeah.
Changing bodies.
Yeah.
You know, as we age, like it's not just a male problem. It's definitely female as well. basically it's adulting at its finest. And for our patients, these conversations are just as important as checking their blood pressure. Maybe just a little more awkward.
Yeah.
So one of the things too to think about when we are talking to our patients is to speak their language. Here's the new thing:
yeah.
body counts. Right?
Yes.
Have you
Oh,
heard of
yes,
that?
Have
yes.
heard it,
What's your
have
body
heard it.
count?
Right.
Never
and-
heard of
heard
that.
it.
What is that?
Oh.
It means something else to you guys.
Right.
Wait, is that the
Roger
number of
that.
people you have in the
No,
trunk?
it
Oh, no.
doesn't. No, it doesn't.
So yeah, I think we have to
Yeah.
start talking their language because some kids are actually really proud of a high body count, not
Yeah.
realizing what that means. So,
Yeah.
Mhm.
Yeah.
and
Yeah.
which can lend itself later to suicide, right? Because you now become made fun of, bullied because you think it's cool at 15 to say you have this high body count. And at 16, 17, people are like not talking to you, not coming near you because
Right.
you've got this high body count. So
Yeah.
it
Yeah.
all ties in.
It really does,
Mhm.
doesn't it? I mean,
Mhm.
that's why we kind of had thought there's so many topics we could choose to talk about this month, but we felt like these two really kind of overlap
Yep.
in some
Yeah.
ways.
Because neither one
Uh,
of them are having open conversations.
Well, and
Yeah,
they're almost mutually inclusive.
Right.
Yeah.
And I think too, I work in a space with vulnerable kids, and most specifically, I work with kids who are transgender and who have HIV or have very high risk factors for contracting HIV, and other members who identify in the LGBTQ plus population. And I think, when we start talking about this, I think what is really interesting is so our transmission rate of HIV in the country is elevated right now. It's more than it has been in the most recent past. And I know about New York City because that's where I work. But the highest rate of HIV transmission right now is amongst adolescent boys.
Is that right?
Yes, and it's extremely high in comparison with the other areas. So, 3 of my 4 kids are boys, and my daughter turned 18 yesterday. So, like, I do tell them all about all this, and
As do I. Yep.
I don't care how weird the conversation is, and what I've seen of my own kids growing up with me as a mother. Sorry, guys, is that sometimes I'm like, all right, TMI. I've learned that from them. Like, you don't, but they're comfortable to tell me much of anything, whether it's how they're feeling emotionally or stuff like, talk about this. So I think it's important, but, Desiree, I think it's one of my interests. And I always talk a lot about, we can debate all day about homosexuality and transgenderism and all these things. And people often ask me, what are you doing working there? And the thing of it is I don't have the lived experience to identify with the people I take care of. It's not mine. It's not my space. I don't necessarily understand how they feel, but what I see is the despair. And that's why I work with them, because I don't feel that anybody should have to suffer the disparities of mental health because they're trying to be how they feel. And that's where I come into that space, and I work and I learn from them and I laugh with them. But, I think we have to talk about these vulnerable populations, teens, just members of the transgender and LGBTQIA plus population. What are we doing with the stigma and the sexuality? And on my end, their risk for HIV and STIs is profound. I'm doing a lot of work to put them on PrEP, which we can talk about later. But, from a behavioral health, how do we support this?
So I think that's probably best served in a one-to-one when they do see their doctors, because it is such a sensitive topic. It might lend itself to be, if they've built rapport with their patient, which is key, then they'll have that one-to-one. But if you're going to reach somebody and really talk to them about their risks for sex or, sexually transmitted diseases, what they're doing right now, you're not going to get that in a group setting. So it's real different than like a different maybe struggle that they're dealing with mentally. This is something that they need to know from a one-on-one, so that they can ask a question, have a question answered, and it's all about them.
Yeah.
Excuse me. So that's what we too, also where I work, we have an LGBTQIA plus huge community, and we have groups built around that. And that is something that with their provider, whether it's a nurse practitioner, their therapist, their psychologist, whomever, that conversation would happen in a very private space, but probably happen often.
Yeah.
You know,
Every time.
right?
Every time.
Mhm.
Mm.
Yeah. So I think that's the biggest thing. We have to start normalizing conversations about sexual health too.
Yeah.
You know,
Mhm.
they're going to open up to us if we break the ice. And, you know, sometimes when I'm working with kids who are a little backward, I'll just say, do you feel safe in the relationships you have? And, you know, that's an interesting, it can go a lot of different ways. I think one of the other things that we don't do is we don't talk to menopausal women about everything that's happening to them, and, you know, intimacy and things like that. It's just like, I think like everything else, this is part of aging.
Yeah.
This is part of your journey in life. And
Yeah.
just like we do with geriatric patients, like, oh, you know, sorry, you have pain, you're old. Like, no, maybe there's really something going on here. So, you know, I think we have to look at that, identify risk factors, ask people real questions. Body counts, right? They're proud of it.
Yeah.
I don't know how many times I've treated chlamydia. It just comes to mind. And I say every single body count, everybody in the body count book, they all have to have this medication too. And a month later, I'm treating them again
Mhm.
because the body count didn't get the penicillin, you
Right.
know, and it's just like, come on, guys, you know,
Right.
how much education is so important. But I think that it's because we don't talk about it enough.
I definitely agree with you. You know, what Desiree, I wonder what strategies you have found most effective when it comes to making patients feel safe enough to open up about sexuality and their mental health together.
So nothing specific, like, you know, I won't poach the question about their sexual habits or any of that. But building rapport with them.
Right.
And this is what I teach my staff, and I hope to instill in my students. But I teach it through the trauma-informed care class.
Right.
You must build rapport. If there's no trust, why on earth would anybody talk to you about something so, you know, private
And vulnerable.
Exactly. So that doesn't happen in the first visit, you know, like the first
Right.
time. It's
Mhm.
definitely something where you're unpacking and uncovering a little more of who they are, and they've opened up a little, and you create that safe space by
Yeah.
allowing them to open up and really validating how they're feeling
Right.
first and
Yeah.
foremost, validating, maybe giving some names to how they're feeling rather than just, you know, giving the name of the emotion that they're feeling, and letting them kind of own that. Maybe the second time they're in there, is there anything else that you want to talk about? And you tippy toe a little bit around that, because it's not something you're going to go all in on, because they might just clam up.
Yeah.
So that's always been my technique, has been to, you know, build that rapport
Right.
first.
Okay. All right. That's good.
All right. So, and then I think like there's a lot of misconception out there about information and, you know, wild things. So some myth busting, I think we should
Okay,
do.
Let's do it.
So, you know, if I don't feel anything, if there's nothing down there that's funny, if I'm not itching, burning, smelling, whatever, I don't have an STI. And I think it's really important that people understand that many and most STIs have little to no symptoms at all. Women tend to experience maybe some more symptoms than men might report, but overwhelmingly, STIs really don't come with a lot of symptoms. Silent does not mean you're safe, you know, just because nothing's yelling at you. It's
When it starts yelling, you're in trouble.
yeah, well, what else? What other myths?
Well, we have contraception is only the woman's responsibility. Nope. No. There's still condoms are still the only method that protect against both pregnancy and STIs, and yet only about 23% of sexually active high school age students report consistent condom use.
Yeah.
Oral sex is safer. How about that one?
Yeah.
How about that myth?
Uh,
You-
I've had a couple of teenagers tell me that in
Yeah.
where I used to work, and I just had, at one point, I just had to have a quick impromptu group And
Yeah.
it was very frank. Listen, guys, oral sex is not safer. And this is why.
Yeah.
So
Yeah.
Yeah.
Well, and that's the thing, you can get STIs from oral sex,
Right.
gonorrhea in the mouth. It probably doesn't taste great. It's just all of these things. And I think the other misconception, which I always wonder about, what kind of conversations are we really having with people, adolescents, when we're prescribing to them? But teenage girls seem to believe that birth control pills prevent STIs overwhelmingly. And I think, and for all of the ladies my age who also believe that, they don't. Birth control pills hopefully prevent pregnancy if you take them as directed, but they don't keep you from getting any sexually transmitted infection.
Correct.
And so I think that's important for people to understand.
Wow.
Yeah.
That's a few.
What about sex? It stops when you're like, what, 55, 60? Isn't that what they say?
Yeah. Uh-huh. Yeah.
Mike
No,
left.
55 years old, and
I
it's
don't-
been at least 5 years. And
Yeah. So the truth,
wow.
truth of that is that's not true.
Oh God, no.
40% of adults that are 65 to 80 that have been surveyed say they're regularly sexually active. And we have seen a huge influx of syphilis. And this is funny. We like to laugh about this, but we have a lot of syphilis being contracted in nursing homes and older folks, residential nursing facilities. So I love that the old folks are giving each other syphilis. Their turn.
I mean, imagine
to take
the irony of still, being sexually active at 70, 75 years old. Like, yeah, I'm a stud, and nope, you got syphilis. Wrong. Congratulations.
Yeah, good job, sir. You made it to 80 with nothing, and here you have
Good
it.
job, sir. You gotta love that, right? Good job, sir.
But no, and this is just too, like, we have to keep our older adults in our conversations. They're living longer, they're healthier, they're, we're amazing. We've done things to keep them alive and keep them out and active. Well, they're going to carry the torch. They're going to be active. So
yeah,
you see, this is why we don't know how to take Mike Freed. He says, what? Sex is crazy in nursing homes. Now, I don't know. Is that a statement? A question?
Freed, do you go to nursing
I mean,
homes
an
for
observation.
sex?
Do you understand why
Or is he
now?
looking to go to a nursing home?
I mean,
Poor Mike. He
I mean,
walks into
like
it.
punctuation.
I'm starting to understand.
Yeah, punctuation means everything. What? Like what? If you were surprised, you should have had like exclamation. It says what?
Wait.
Sex is crazy in nursing homes.
Yeah.
Okay.
That's a statement.
We're
Good.
We're not.
And he confirms.
Statement.
And he confirms.
Is this lived experience?
Wow. Freed, we're gonna talk before your next show, kid.
I think you should reach out to him.
Yeah. We'll be reaching out, Mike.
You
Freed,
okay,
are you
Mike?
okay?
Yeah. Yeah. Right.
Would you like a code blue?
I think he needs one.
Yeah.
So a few quick nurse-approved tips are getting tested regularly, knowing your status is sexy, use protection always, and talk it out. Consent and communication are a lot hotter than guesswork. Don't skip your annual checkup. But about 70% of patients say that their provider doesn't bring up sexual health. So nurses, let's be the one to bring it up. It's not awkward if we're looking at their private parts. If we're talking about their cholesterol, what's going on inside them, we can talk about that.
Yeah.
Why did you look at me when you said cholesterol? What?
How is the cholesterol?
Well,
I don't know. I haven't gotten it retested yet.
Because we can see it from here. That's why.
They're worried. They're worried about me. My triglycerides were 338. Yeah, that
Okay.
was that was pretty high. I think.
Okay.
But I've started walking again, and I feel better. So I'm gonna get it
No.
What's the
retested.
diet?
Okay. I'm gonna get it.
And sex burns calories. So Stacy, right? That's your wife's name.
Yes.
Stacy.
Yep.
Here you go.
You're on
Stacy,
alert.
pay attention.
Sorry, Stacy.
And
Yeah.
apparently, Mike Freed visits the nursing homes. That's why his cholesterol is so low. So now we understand. And we
Oh,
get
Mike
it.
Freed, you're on to it.
I'm sorry. Go ahead.
That's a whole other
Yeah.
topic.
So I think, just having these conversations. And then when we talk about, so the CDC right now is telling us that everybody who's at risk to contract HIV should be tested annually for HIV. And of course, there are certain things that make people at higher risk. But my advice is if you have sex, I don't care who it's with, you should be tested annually for HIV. And, people at high risk every 6 months. 1 out of every 7 people who have HIV have no clue. When we looked at people who have what we consider to be high risk behaviors, 70% of them have never had an HIV test. So, it's your insurance will pay for it. It's simple. Get it with your annual blood work. It should be being offered to you. I will tell you, I was for my annual physical, last week, it was not offered to me. I asked for it, but I had to ask for it. Mm-hmm. So, you advocate for yourself when your provider's not speaking up, but you should get tested. And, practice safe sex. If you feel like you are putting yourself at risk, there is PrEP out there, and this is pre-exposure prophylaxis. And if you are knowingly having sex with somebody who has HIV, and that's okay. We treat people with HIV, they have no viral loads, which statistically means they cannot transmit the virus. But if you want an extra layer, you can also take a daily medication that we prescribe to people with HIV, and you can, avoid contracting it even further. So I think, going kind of round robin around the table, what's the one message you hope that people take from today?
I think for me today, the big takeaway is it's something I've always said. If you need to take more responsibility for the people around you, whether you like them or whether they're not your favorite staff member or colleague or whatever. We are all our brother's keeper. And I think if you just check in with people regularly and that somebody's had a disturbing event in their life, just say, I see that, and I care. That's it. It literally takes 10 seconds to tap out a text that says, I know you're having a hard time right now and I care. And if for nothing else, at least I know that I've let them know I see you.
Yeah. That's all right.
I think a little along that vein, I think a lot of times one of the biggest problems is because of the stigma. We try not to have a stigma, but we don't know what to say. And by we, I don't mean people in the mental health space, because a lot of us are more comfortable having that conversation. Some aren't. But for the nurse who doesn't know, the layperson watching who doesn't really have the language behind it or the experience behind it, to just say, I'm listening. I'm here to listen. I'm not sure what's going on. I notice something's different. If you want to talk, I am here no matter what time. Please call me. Like, I'm here. Mm-hmm. Again, that lends itself to things look a lot different at 3 o'clock in the morning than they do at 3 o'clock in the afternoon. And sometimes just mentioning that in itself could be a little bit of a nightlight for somebody.
True. Mm-hmm. Very true.
Yeah.
Ashley?
Yeah, I think too, just, talking to people in general. I always say, Mike, before he left, just said that he says hello to everybody, talk to whoever's out there, just, see how people are doing. And recognize also, I liked his point about how he spoke about the guy that he doesn't even like him is probably the guy who helped him the most at some point in time. And, just recognize that. And again, ask people you're with, whether it's colleagues, students, whoever, like, hey, you okay?
Yeah.
Or do you want to talk about it? And then, again, talk to your kids. Mm-hmm. Do not be afraid to talk to your kids. I mean, first and foremost, you're their parent. You have every right to know everything you want to know about them. But there's also a way to approach that. And it's kind of that same developing trust that Desiree, you've talked so much about with a provider and a patient. A parent and a child needs that too. Like, yes, it's an authoritarian relationship when you're in a parent and a child, but there has to be some kind of trust there, because they need that. They need a supportive person who won't judge them, who will help them navigate what they're dealing with, and kids often tell us, well, I didn't tell them because I was going to get in trouble. Mm-hmm. And it's like, yeah, you're going to be grounded for the rest of your life, but thanks. Like, here's a hug. So, it's a dance, but I think
Mm.
we got to teach parents how to have conversation
Mhm.
with their kids
Mhm.
because it is incredibly awkward. It's a weird thing. So, all right.
Okay, well, I guess now it's the listeners' turn. Why don't you let us know what does sexual health mean to you guys right now? Is it confidence? Is it safety, connection? Or maybe it's just not blushing every time your provider asks, "Are you sexually active?" We'd like to hear from you guys.
Yeah.
Yeah. And furthermore, of course, we always want you to be checking in on a friend who's gotten quiet. You could even ask your provider about an HPV vaccination. There's just so many takeaways from today.
I think that's another thing I talk a lot about with people. Cervical cancer is preventable. Here's another thing that's preventable that we should just scoop up and it's like
Yes.
the best ice cream in the summer.
Yeah.
The vaccination so HPV is actually the most commonly contracted STI in this country. And there's vaccination for it, and it causes cervical cancer. HPV causes cervical cancer, and the vaccination is not just for women. It's for men too, because we have to, again, that whole slogan of protect each other.
Yeah.
Right. And,
Mhm.
Our kids as adolescents, I think do they start it at like 11 years old?
Now
Nine,
it's yeah,
maybe.
it's 11.
And so, parents, if you believe in vaccinating your kid, that's probably another conversation. But, male children too, not just our female. And for the dads and moms out there with teenage daughters, you'll appreciate the people who choose to vaccinate their male kids. And we've extended vaccination age to in the late 40s now. So adults who never had this opportunity as a child have the opportunity to vaccinate for. So I think it's important.
Yeah, absolutely.
All right. So I think we should play trivia.
Okay,
we made
little
some
trivia. Okay.
Anybody who wants, I think Mike Freed's going to win.
Oh,
Mike Freed's the only.
if it has anything to do
commenter.
with nursing homes, he's 100% gonna win.
Okay. We're going to start with what is the most common sexually transmitted infection in the U.S. today?
Oh, just keep
Oh,
See if they were listening.
okay. Yeah. Is it gonorrhea, chlamydia, HPV, or herpes?
And it is HPV.
Ah.
And truthfully, if you are unvaccinated for HPV, the statistic is that you will get HPV.
Yeah.
There's no margin of maybe you'll get it, you will. That's where we're at in this day and age.
Yeah.
42 million Americans are currently infected with HPV. I was like, ew, that's a lot.
Yeah.
And about 13 million new HPV diagnoses are made yearly just on routine PAPs. So, do that math. This is a large majority.
And that's one of the ones with no real symptoms,
None at all.
Right.
Men are always asymptomatic. Women sometimes will tell you they have a little bleeding here and there, spotting, but nothing. But it causes cervical cancer. It kills people.
Yeah.
And it's no
linked with all mouth cancers in males as well.
Yeah. Wow.
Mm-hmm.
That's Desiree's myth. So
That's it.
there it is.
All right. True or false? You can get an STI from oral sex.
You can't get.
You can't get one from oral sex. I'm sorry.
Yeah. So what do you think?
What do you think, Desiree?
I'm pretty sure that might be false.
You're right. It's a big fat false.
Yeah.
Oral sex can definitely be transmitted from infections such as gonorrhea, herpes, HPV, and syphilis. And even lice.
Crabs. Let's just use the teenage terminology. So people often have oral crabs from their body.
That just sounds bad.
No,
I'm gonna wish that on people. I wish you get oral crabs.
In their eyelashes, in their eyebrows.
Wow.
Stop it.
Oh yeah.
Seen it.
Yeah.
Seen it.
Dawn, find me pictures of that.
I don't think I
You like how I
want
did that?
to
You like
see
how
pictures of that?
You like how I got the stat in there? Stat.
Yeah,
Find
I
me.
do not want that in my Google.
I need a picture. of eyebrow
Because if I
crabs.
open up my Google and I see that kind of stuff, I'm like,
Eyebrow crabs
"Ugh."
immediately.
Listen,
no.
it's lice.
That's crazy.
That's
Uh-huh.
disgusting.
Yep, yep.
That is disgusting.
Okay, number 3. What percentage of adults in the U.S. report never having had a conversation with their healthcare provider about sexual health? Is it 10%, 30%, 50%, or 70%?
I'm gonna go 70. I'm gonna say
Yeah,
that's
but
high.
You're right.
And
I'm
it
gonna
is.
say
It's
that.
It is.
70.
It's 70% that most patients are waiting for we as providers to open the door to this conversation. And again, I can't stress to you enough, ask your teen patients what's going on with all of it.
Yeah.
Alcohol, glue sniffing, whippets, and sex. Most adults with substance abuse problems, as we mentioned earlier, begin using in their early teens. Let's get ahead of this while we have them in our exam room.
Yeah.
Yeah.
All right. So I think, wrapping up, just, happy to get out there and talk about it. And hopefully you learn something if you didn't know, or you feel more comfortable having conversations or reaching out, looking at just different things. We always kind of ask if there's anything anybody wants to plug. So I'm jumping in. So I want to plug our breast cancer walk that we're doing in October for Code Lavender. And we have a few people that have signed up to join us and walk in Central Park in New York City on October 19th. All money that we've raised, I think it's close to $1,500 now,
Yeah.
is going to breast cancer, care, treatment, and families. We have an incredibly exciting guest coming up on that show. He is a guy that his mom had breast cancer, and him and his brother sat down one day and said, you know what, we got to do something. So they truly fund the hockey adventures of young kids in this country whose mothers have breast cancer,
Wow.
because they understand, and they're
Nationwide.
their home base is here in New Jersey. So
Yeah.
we're pretty fortunate that, you meet people in the weirdest ways, and we'll talk about it next time, but
Yeah.
we want to get him on here and really learn about what their organization's doing, because they want to help more people.
Yeah.
But it's and they've been at it for 5 years.
So exciting.
So I think Dawn's going to put the link up for
Yep,
our
already up.
for
Put it
our
on that
breast
page.
cancer walk. So
Great.
for real, come walk with us. It'll be a great time. And it, just if nothing else for your own mental health, get out there, meet some new people, and walk for a cause
Walk
that's
with the
near and dear to
nurses.
me. Yeah.
We're taking more members on our team.
Anything you want to plug?
Actually, it's kind of funny, but yeah, I do. I get a lot of comments on my hair. And look, yeah, it was red when I grew up, but it's not anymore. It's gray. Okay. So my girl, whose name is Alyssa, works at the Secret Garden in Staten Island, New York. Phone number 718-815-5900. She is the genius.
Find the site, Dawn. Find the site.
For real.
What's the name again?
It's the Secret Garden in Staten Island.
It's already in the comments.
And
Outstanding.
yeah, oh my God, she's
What
just
was her name though?
Alyssa.
That's my daughter's name.
Oh, well.
There you go.
Yeah, she's the one that makes all of this possible.
Excellent. All right, Desiree, anybody you want to shout out to or put out there for people to connect with?
Now, if anyone's in the Brooklyn area, on October 22nd, we will be having a stigma-free event. We will be the first hospital in New York to declare ourselves a NAMI stigma-free hospital.
Amazing.
And yeah, it's a community event, and we will have a bunch of resources for all of the community. And again, I just think it's really huge. And New Jersey's done it. We've got it everywhere. Stigma-free. We've raised the flag, but we will be the first in New York. So very
And this
excited
is
about that.
at Maimonides.
Yes.
I don't know if I ever mentioned that, but Maimonides on 8th,
It's going to be on 10th Ave.
10th. Okay.
Yep. Mhm.
Yep.
On October 22nd, 11:30 to 2. And if you're in the Brooklyn area, please come by. It will definitely be fun.
That's exciting.
Yeah.
Awesome.
What day of the week is that?
That would be I believe it's a Wednesday, actually. It's Wednesday.
Nice.
Yeah.
A lot of my patients are your patients. It's so funny because
Oh.
many of the kids I see on different levels see practitioners where you, and I worked at my Maimonides
Yeah.
in my younger years, in my younger leadership years. So
Yeah.
very near and dear to my heart. Anybody else have anything to plug? The people behind the scenes.
Oh,
Well, you had
there
a plug.
Oh, did you fall asleep back there?
I did not fall asleep back there.
I
Well, two
think
things.
I
I
saw
want
you
I
do-
want to wish everybody that's participating in the Tunnel of the Towers run tomorrow good luck.
Oh, that's tomorrow.
Yeah, it's tomorrow
Yeah.
in New York. That really is an amazing event.
So what is it? Tell people what Tunnel of Towers is.
Again, it's founded by the brother of Steven Stiller. He was a New York City fireman that famously ran through the Brooklyn Battery Tunnel when all the traffic backed up. So apropos, the run starts in Red Hook down there and then goes through the Brooklyn Battery down the west side. The Tunnel of Towers Foundation is an unbelievable organization.
It is.
Everything they do for first responders, military, anybody, you look them up.
That's awesome.
Donate
Agreed.
$11 a month.
Agreed.
What they do with the money is second to none. And that event, like I said, when you come out of the Brooklyn, it's only a 5K. It's not crazy, and it's a run walk for anybody not interested in running. The jogging days are behind me. So walking is much more convenient. But when you come out of the Battery, you actually see the towers right in your view, and the whole roadway on the right hand side is lined with FDNY members, NYPD, and Port Authority members, and each one is holding a banner for everyone that was lost in the line of duty on 9/11. So you get to hear the numbers, to hear the 343, 23, 37. Like it doesn't really hit till you see those banners, and you're like, holy shit! Like how long is this line? Like it just keeps going, and in every single person's face, it's really it's a moving. You got to do it at least once. I don't like running, but you got to do it at least once, and then
I would
can-
love to do
Next
it
year.
next year. I would
Yeah.
love to. Love to.
I mean, have a cold Lavender team, 100%.
yeah.
I will 100% get Michael to participate. Michael, you have no choice. Now,
Wait, which Michael?
not Freed. Freed's busy in the nursing homes. He can
Getting his own exercise.
and I had
Reed could probably run a marathon.
he probably could, sadly, if he could stay out of the hospital. And I think the takeaway when you were saying like if you're hoping somebody took something away from the show, this is the hoodie I was telling you about that I have, and it's real simple, but the message is I think wraps up what you guys were talking about today. The front says be kind, and I always say I tell my kids it costs nothing to be kind, and my girls, maybe it was intrinsic, maybe it was because I taught them, but I one of the things I love the most about them is both of my girls. It's always been that way. I mean, they're 22 and 17 now, but thank you and please does not stop coming out of their mouths when we go out. It's just simple, like little things like that. So I think this message resonates with them, and it says everybody you meet is fighting a battle you know nothing about.
Sure.
I think if you keep that in your mind when you deal with people that, like you guys were saying, like not everybody's really going to give you any of those warning signs. Some people are going to be smiling right to your face, and you have no clue what's going on behind the scenes. But no, I really think you guys did great today. This was a great show.
Well, thank you.
Yeah.
Thank you.
So next month we
Well
will
done,
be
sister.
on to talk about breast cancer awareness, probably a little shorter, but such a important thing. And I think I don't think there's anybody that I could talk to that hasn't known somebody impacted by this. And
Male, female, child,
Yeah.
adults. This touches everybody.
it does. And then we're going to do a second episode in October, and we are featuring Blue, but we're going to have so much fun for our triple love of Halloween. And I got into the black hole last night, reading about scandalous medical research
Don't
and
ruin it.
procedures and things.
Don't
he did.
ruin it,
So
Ashley.
Here we come.
Don't ruin it.
I was in the abyss.
I am so excited about this. I
Yes.
mean, I'm so excited about both shows. I really am. And I'm very pleased with today. We did great. Good work,
That was
ladies.
great work.
Yes.
Great work.
Thanks, gents.
All
Thank you for
right.
having me.
All right,
Thank
guys.
you.
Have a good one.
Thank you.
All right.